What your doctor says in those few seconds during a blood pressure check can shape the next decade of your life more than almost any other routine measurement in medicine. A reading like 148 over 78 often sounds deceptively reassuring to patients, especially when the lower number appears normal. Many people instinctively focus on that second number, the diastolic pressure, and assume that if it looks acceptable, the situation is under control. After more than 2 decades in cardiovascular medicine, I can tell you plainly that this assumption has led countless individuals down a dangerous path, one that often ends in preventable complications. Blood pressure is not just a pair of numbers. It is a dynamic reflection of how your heart, blood vessels, kidneys, brain, and hormonal systems are interacting in real time. And as you age, particularly beyond the age of 60, the meaning of those numbers changes in a profound and clinically significant way. When we measure blood pressure, we are capturing two distinct physiological moments. The first number, systolic pressure, represents the force generated when the heart contracts and ejects blood into the arterial system. It is the peak pressure your arteries experience with every heartbeat. The second number, diastolic pressure, reflects the pressure within the arteries when the heart relaxes between beats, a baseline level that maintains continuous blood flow to vital organs. For many years, clinical emphasis was placed heavily on diastolic pressure. Elevated diastolic readings were considered the primary driver of cardiovascular risk, particularly in younger and middle-aged adults. That perspective was not incorrect, but it was incomplete. What we have learned through decades of longitudinal research is that the relative importance of these two numbers shifts significantly with age. After the age of 60, systolic pressure becomes the dominant predictor of cardiovascular events, including heart attack, stroke, heart failure, and even cognitive decline. This shift is not arbitrary. It is rooted in structural and functional changes that occur within the arterial system over time. In youth, arteries are highly elastic. They expand with each pulse of blood and recoil efficiently, helping to dampen the force generated by the heart. This elasticity acts as a buffer, protecting delicate microvascular networks in organs like the brain and kidneys from excessive adduct. The arterial walls contain a high proportion of elastin and a protein that allows them to stretch and return to their original shape. With aging, however, this elasticity diminishes. Elastin fibers gradually degrade and are replaced by stiffer collagen. The arterial walls thicken, calcification may occur, and the vessels lose their ability to accommodate the surge of blood with each heartbeat. This process is often referred to as arterial stiffening, and it is a hallmark of vascular aging. As arteries become less compliant, the same volume of blood ejected by the heart generates a higher peak pressure. The systolic number rises. At the same time, the recoil that normally sustains diastolic pressure is reduced, so the diastolic number may remain stable or even decline. This divergence creates a pattern known as isolated systolic hypertension, and where the top number is elevated while the bottom number appears normal. It is precisely this pattern that misleads so many patients. A reading like 148 over 78 fits this profile. The lower number does not offer protection in this context. In fact, the widening gap between systolic and diastolic pressures, known as pulse pressure, is itself an independent marker of cardiovascular risk. The clinical significance of isolated systolic hypertension has been extensively documented. Large-scale epidemiological studies, including the Framingham Heart Study, demonstrated that systolic pressure is a stronger predictor of cardiovascular events in older adults than diastolic pressure. Franklin et al., 2001. Each incremental rise in systolic pressure above optimal levels correlates with a measurable increase in risk. Further evidence comes from randomized controlled trials such as the Systolic Hypertension in the Elderly program SHEP, which showed that treating isolated systolic hypertension significantly reduced the incidence of stroke and major cardiovascular events. SHEP Cooperative Research Group, 1991. More recently, the Systolic Blood Pressure Intervention Trial, SPRINT, provided compelling data that more intensive systolic control, targeting levels below 120 millimeters of mercury in selected populations, resulted in lower rates of cardiovascular events and mortality compared to standard targets. SPRINT Research Group, 2015. These findings fundamentally changed clinical guidelines. Organizations such as the American College of Cardiology and the American Heart Association now emphasize stricter systolic targets, particularly for older adults who can tolerate treatment. Understanding the implications of elevated systolic pressure requires looking beyond the numbers themselves and examining the organs most affected by chronic exposure to high adult. The brain is one of the most vulnerable. It depends on a finely regulated blood supply delivered through an intricate network of small vessels. These vessels are exquisitely sensitive to mechanical stress. Repeated exposure to elevated systolic adduct causes microvascular damage. The vessel walls thicken, lumens narrow, and the ability to regulate blood flow becomes impaired. Over time, this can lead to small, often silent infarcts, areas of brain tissue that lose their blood supply and function. Accumulation of such damage contributes to cognitive decline and vascular dementia. Vascular dementia is frequently underrecognized and can be mistaken for neurodegenerative conditions such as Alzheimer's disease. While the clinical presentations may overlap, the underlying mechanisms differ. Importantly, vascular contributions to cognitive impairment are, to a significant extent, preventable. Effective blood pressure control is one of the most powerful interventions available for preserving cognitive function in older adults. Idicola et al. 2016. The heart itself is also directly affected by elevated systolic pressure. When the left ventricle must pump against increased resistance, it adapts by thickening its muscular walls, a process known as left ventricular hypertrophy. While this may initially help maintain cardiac output, it ultimately leads to reduced compliance and impaired filling. Over time, this can progress to heart failure with preserved ejection fraction, a condition that is increasingly common in aging populations and challenging to treat. The kidneys, which filter the body's blood supply continuously, are another major target of hypertensive damage. The delicate glomerular capillaries are susceptible to high adduct, leading to progressive scarring and decline in renal function. Chronic kidney disease often develops silently, becoming apparent only after substantial nuxan has occurred. The eyes provide a visible window into the effects of hypertension. Changes in the retinal vessels, collectively referred to as hypertensive retinopathy, can be detected during routine examination. These changes mirror similar ASIB occurring in less accessible vascular beds, including those in the brain. Taken together, these effects underscore a critical point. Elevated systolic pressure is not an isolated issue. It is a systemic condition with far-reaching consequences. Current clinical guidelines generally recommend a systolic target of less than 130 millimeters of mercury for most adults over 65, provided that treatment is well tolerated. This recommendation reflects a balance between reducing cardiovascular risk and avoiding potential adverse effects such as hypotension and falls. Individualization remains essential, but the overall direction of evidence is clear. Lower systolic pressure within safe limits is associated with better outcomes. Lifestyle modification remains the foundation of blood pressure management. Reducing dietary sodium intake has a well-established effect on lowering blood pressure. When the World Health Organization recommends limiting sodium consumption to less than 2 grams per day, equivalent to approximately 5 grams of salt. Older adults are particularly sensitive to sodium, as renal excretion becomes less efficient with age. Weight management also plays a significant role. Excess body weight increases vascular resistance and contributes to elevated systolic pressure. Even modest weight loss can produce clinically meaningful reductions. Regular aerobic exercise improves endothelial function and arterial compliance. Activities such as brisk walking, cycling, and swimming performed consistently can lower systolic pressure by several millimeters of mercury. Exercise also has beneficial effects on metabolic health, inflammation, and mansic well-being. Psychological stress is an often underappreciated contributor. Chronic activation of the sympathetic nervous system leads to sustained elevations in heart rate and vascular tone. Interventions such as mindfulness, meditation, and structured relaxation techniques have been shown to reduce blood pressure and improve overall cardiovascular health. Despite these interventions, many individuals will require pharmacological treatment to achieve target blood pressure levels. This is not a reflection of failure, but rather an acknowledgement of underlying biological changes that cannot be fully reversed through lifestyle alone. Antihypertensive medications, including ACE inhibitors, calcium channel blockers, and thiazide diuretics, have been extensively studied and proven to reduce the risk of major cardiovascular events. Their use should be viewed as a proactive measure to mitigate risk rather than a last resort. An often overlooked but valuable tool in blood pressure management is home monitoring. Office-based measurements provide only a snapshot and may be influenced by factors such as anxiety, a phenomenon known as white coat hypertension. Conversely, some individuals exhibit normal readings in clinical settings, but elevated pressures in daily life, a condition referred to as masked hypertension. Regular home monitoring offers a more comprehensive picture of blood pressure patterns. Using a validated upper arm device, taking measurements at consistent times, and maintaining a log can significantly enhance clinical decision-making. Studies have shown that home monitoring is associated with better blood pressure control and improved adherence to treatment. Sturgio et al. 2018. Ultimately, The management of blood pressure after 60 requires a shift in perspective. It demands an understanding that the cardiovascular system has changed and that the metrics we rely on must be interpreted in that context. The systolic number, once considered only part of the equation, becomes the primary indicator of risk. A reading like 148 over 78 should not be dismissed because the diastolic value appears acceptable. It should prompt a thoughtful evaluation and, where appropriate, intervention. The goal is not merely to normalize numbers, but to preserve function of the heart, the brain, the kidneys, and the vascular system as a whole. It is about extending not just lifespan, but health span, maintaining independence, cognitive clarity, and quality of life. Every patient's situation is unique. Clinical decisions should always be made in consultation with a qualified healthcare provider who understands the individual's medical history, comorbidities, and UPCHAR goals. However, understanding the principles outlined here empowers individuals to engage more effectively in those conversations. Monitoring your blood pressure regularly, paying attention to the systolic value, adopting evidence-based lifestyle changes, and adhering to prescribed treatments are all steps that can significantly alter your long-term trajectory. The most important takeaway is simple but profound. After 60, the top number matters more than most people realize. Recognizing that fact and acting on it can prevent outcomes that are otherwise all too common and often devastating.